Hello, good evening दोस्तों. Today we'll be discussing topic of abdominal compartment syndrome. So, abdominal compartment syndrome where the abdomen becomes a fixed compartment, and due to increasing pressure there is a pathology created inside. So, intra-abdominal hypertension IAH, that is sustained or repeated pathological elevation of the intra-abdominal pressure of more than 12 millimeter of mercury. So if it is more than 12, then it is problem. Normal is 5 to 7 millimeter of mercury. So what are the grades of intra-abdominal hypertension? It is from grade 1 to grade 4. So grade 1 is 12 to 15 millimeters of mercury. Grade 2 is 15 to 20 millimeters of mercury. Grade 3 is 20 to 25 millimeters of mercury. And grade 4 is more than 25 millimeters of mercury. Then we go ahead with, it is measured with help of detecting the pressure changes following instillation of 25 ml of sterile saline in the end of expiration in the supine position after ensuring absence of abdominal wall contraction. So, abdominal perfusion pressure, that will be mean arterial pressure minus intra-abdominal pressure. So, abdominal compartment syndrome where there is sustained intra-abdominal pressure more than 20 mm of Hg with or without abdominal perfusion pressure less than 60 mm of Hg, and it will be associated with new organ dysfunction or failure. So we'll go through this again, that there is sustained intra-abdominal pressure more than 20 mm of Hg with or without abdominal perfusion pressure less than 60 mm of Hg associated with organ dysfunction or failure, that will be new. So it could be primary or it could be secondary. Primary is generally associated with injury or disease in the abdominopelvic region and it requires urgent prompt intervention. And secondary, it could be due to condition that do not originate in the abdominopelvic region. Then what are the causes? Causes of increased intra-abdominal pressure. In the retroperitoneal region, it will be pancreatitis or pelvic or retroperitoneal bleeding causing hematoma. Abdominal aortic artery, abdominal aortic aneurysm rupture, abscess. So these are the retroperitoneal causes. Then we'll go ahead with intraperitoneal causes, that is hemoperitoneum. It could be due to abdominal aortic aneurysm rupture, gastric dilatation, bowel obstruction, mesenteric venous obstruction, pneumoperitoneum, abscess or visceral edema. Then parietal, it could be due to burn, scar, repair of the gastroschisis of omphalocele, reduction of the large hernia, laparotomy closure under tension, mechanical ventilation. Then chronic causes of increased intra-abdominal pressure, that is central obesity, ascites, any large intra-abdominal tumor, COPD and pregnancy. This is not COPD, CAPD, sorry. Then we'll go ahead with pathophysiology. Pathophysiology is how we'll see that there is increase in intra-abdominal pressure. So when there is increased intra-abdominal pressure, there will be increase in vascular resistance and decreased venous return. So this will result in increased myocardial workload. So heart's workload will be increased and that will result in changes in the pulmonary artery wedge pressure. So increased myocardial workload will result in decreased cardiac output. Also decreased venous return will affect the cardiac output. So decreased cardiac output will result in decreased mean arterial pressure, which in turn will result in decreased abdominal perfusion pressure in the viscera and decreased gut perfusion. So it will result in gut ischemia and result in stress ulcer over time. And ischemia will time when there is improved perfusion after some time will result in ischemia reperfusion injury, and this cycle will result in again increased in intra-abdominal pressure. Then we see that increase in intra-abdominal pressure will result in pushing diaphragm up, resulting in respiratory restriction. and atelectasis, which will result in hypoxia, decreased oxygenation. Also, intra-abdominal pressure will result in decreased renal blood flow and result in renal ischemia, which will aggravate or positive feedback to the renin, angiotensin, aldosterone system, result in fluid and water retention, and increase in the intra-abdominal pressure. And again, increase in intra-abdominal pressure will result in increased intrathoracic pressure, raised JVP, and decreased cerebral venous return, which will result in increased intracranial pressure and affects or decreases the cerebral perfusion. That's the brain's blood supply being affected and compromised. Also, in increased intra-abdominal pressure, the peripheral venous return will be decreased and there will be an increased chance of DVT. Then we come for, that is secondary abdominal compartment syndrome. It will be related to the capillary leak and fluid restriction. So how does it happen? Commonly when there is acidosis, that is pH is less than 7.2, hypothermia or coagulopathy, these are the lethal triad of trauma or injury. Massive blood transfusion more than 10 units in 24 hours, severe sepsis, shock, massive fluid resuscitation, more than 5 liters of colloid or more than 10 liters of crystalloid in 24 hours, in the presence of capillary leak with positive fluid balance, or major burns. So how do we manage these? Intraluminal decompression, management of intra-abdominal hypertension where the intra-abdominal pressure is more than 12. So intraluminal decompression with help of NG tube decompression, flatus tube, adding prokinetic like metoclopramide, decreased enteral nutrition, enemas, and colonoscopic decompression. If there is any SOL, then we have to evacuate the intra-abdominal SOL, percutaneous drainage of some collection, surgical evacuation of any bleeding or abscess, improve abdominal wall compliance with help, then sedation and analgesia, muscle relaxation, escherotomy in case of burns, optimize perfusion by adequate resuscitation, and goal directed resuscitation. So in case of refractory increased intra-abdominal pressure, where after regular measurement we cannot decrease the intra-abdominal pressure and the intra-abdominal pressure is more than 20 mm of Hg with organ dysfunction, we'll go ahead with surgical abdominal decompression. Now we'll go ahead and try and understand some aspects of abdominal compartment syndrome. So abdominal compartment syndrome is the physiologic consequence of acute severe abdominal distension with intra-abdominal hypertension, including hypoxia, hypoventilation, decreased blood pressure, cardiac output, and renal and visceral perfusion. So all the organs are affected, mostly visceral organ, renal, cardiac, and overall the decreased of blood flow. It is more than equal to 12 millimeters of mercury with organ dysfunction, and it improves after abdominal decompression. Then some important point, these are most patients of abdominal compartment syndrome will have tense abdominal distension with elevated intra-abdominal pressure. They will have difficult ventilation due to elevated airway pressure, low blood pressure due to decreased venous return and low cardiac output, decreased urine output, visceral hypoperfusion with progressive acidosis, and improvement of these findings on abdominal decompression as we have seen ahead. Inappropriate response to resuscitation is another sign of abdominal compartment syndrome. So we have to always be cautious when we are resuscitating. If there is no response, then we have to go ahead with decompression of the abdomen. We have seen the grades and how is it measured. So it is commonly used is the bladder pressures to monitor either intermittently or continuously, and it is done by connecting a transurethral Foley's catheter to a pressure transducer for the patient who are in risk of developing intra-abdominal hypertension or abdominal compartment syndrome. So recognition of high risk patient is the very important aspect of the treatment, since delay will be associated with increased morbidity and mortality. So appropriate monitoring of the abdominal pressure, early implementation of the preventive measure like neuromuscular relaxation, prompt decompressive laparotomy are very important for successful treatment. Preventive measure like the neuromuscular relaxant, removal of the ascites, paracentesis of the ascites, and pressure limiting ventilation strategies to avoid ventilator induced lung injury. Then in case of sudden release of the intra-abdominal pressure by the decompression, the visceral reperfusion may cause acidosis and hypotension in some patients. So adequate preload and maintaining of the appropriate ventilation before decompressive laparotomy, it will help us avoiding this syndrome. So we have to try and maintain adequate preload and appropriate ventilation before the decompressive laparotomy or decompressive surgery. Other technique for temporary abdominal wall closure, which are negative pressure wound therapy or temporary abdominal closure with help of prosthesis, that could be Bogota bag or Whitman patch. Enteral feeding with open abdomen is safe, so it could lead to decreased bowel edema and early closure of the abdomen, so it can be used. And in general, abdominal re-exploration should be performed in 24 to 48 hours so that abdomen can be closed as soon as the physiology improves and visceral edema has subsided. The time between initial decompressive laparotomy and the re-exploration predicts the future timing of the primary facial closure, that is the definitive abdominal wall closure. Then combination of hypertonic saline resuscitation and wound vacuum therapy, that is negative pressure therapy, and early surgery for sequential facial closure has been suggested and is helpful. Component separation techniques may be helpful in case of delayed closure, and bilateral myofascial advancement flap can be used as technique for patients with abdominal compartment syndrome, and primary closure with help of biologic and acellular dermal prosthesis can also be used. So these were the topic of abdominal compartment syndrome. So we'll see some indication of temporary abdominal closure in trauma patients. So it could be cases of damage control approach, that is acidosis, hypothermia, coagulopathy, when there is large volume of blood loss, combination of major vascular and GI injury, when we have planned for a second look surgery, in case of intra-abdominal packing which is placed, unable to achieve a tension-free facial closure, that is closure of abdomen, risk of abdominal compartment syndrome, and treatment of the abdominal compartment syndrome. These are the common causes where we use temporary abdominal closure, and it is useful for managing the patient which is not having regular physiology or having abnormal physiology. Now we'll go through quickly about the abdominal closure in short. So what are the main principles which are followed here? It is done to quickly prevent the visceral prolapse, drain the edema fluid, and prevent abdominal compartment syndrome and later facilitate secondary closure. So in case of emergency or when we are considering a damage control approach, facial closure is not initially recommended. Instead, we use a temporary abdominal closure, as you have seen. That could be Bogota bag or opsite TM sandwich or vacuum assisted technology. Important points which I wanted to discuss are the optimal temporary abdominal closure characteristics. So it is useful for control of the abdominal viscera to prevent further contamination of the abdominal cavity, then prevent injury to the abdominal viscera, control and quantify the effluent which is coming from the abdominal cavity, preserve skin and soft tissue integrity, avoid radiographic artifacts that could complicate other diagnostic and therapeutic modalities, avoid tension to future leading to abdominal compartment syndrome, prevent fusion of the visceral block to the abdominal wall, so there will be space, promote medialization of the facial edge, preserve facial integrity for later definitive closure, ease of placement and cost effectiveness. So these are some points which are important for abdominal closure and will be helpful in management of abdominal compartment syndrome. Thank you for listening and keep studying, keep growing, and please like, share and subscribe. Your efforts will help us motivate and keep us going and bringing you new content. Thank you. Keep studying.